Hello, welcome again to Miami Community Health. I'm Dr. Anthony Gonzalez, and I'm your host for another important health topic. So we're going to talk today about juvenile arthritis. Juvenile means children. Children can have arthritis? Yes, the numbers are there are about 300,000 kids in the U.S. with arthritis. I was astounded to hear this as well, and I couldn't believe that this could be possible. So obviously, to understand about juvenile arthritis, we have to bring a pediatric rheumatologist. A rheumatologist is a doctor that deals with these type of inflammatory conditions. And so from Nicholas Children's Hospital, we have Yonit Sterba. Welcome.
Thank you.
All right. So Yonit, first tell us a little bit about yourself. Pediatric rheumatologist. What is that?
So we take care of kids with certain conditions where the immune system gets confused and attacks the body. So in the case of juvenile arthritis, our body gets confused and is attacking the joints. But there are other autoimmune conditions where there may be other organs involved.
And yeah, we were talking about that. What are some of the other conditions that you commonly take care of that people would be astounded to hear that they happen in kids?
So the most common one is juvenile arthritis, but then after that, systemic lupus we see in kids and more often in teenagers. And then other conditions include juvenile dermatomyositis or polymyositis, and then vasculitis, and some other more rare conditions.
All right. So first, let's start off with juvenile arthritis. What is it?
So the name of the condition is juvenile idiopathic arthritis, and juvenile means it happens before the 16th birthday. So it happens in kids and teenagers. If you develop this condition after the 16th birthday, it's not considered to be juvenile anymore. Idiopathic means we don't know the reason why it happens. It doesn't have a known cause, and arthritis is inflammation of the joints. So these are kids before their 16th birthday. They present with inflammation in their joints, and we need to have at least 6 weeks of symptoms or 6 weeks of inflammation to say that a child has juvenile idiopathic arthritis. We also call it JIA for short.
Okay. And how common is it? I made a comment of 300,000 people. You were
Yes.
telling me that it's difficult to even know how many people have it. So how common do we see it?
So the estimated number in the U.S. is around 300,000 children. But the reason why it's difficult to know how many children truly have it is because there are a lot of kids that will outgrow the arthritis. So although it's considered a chronic condition, kids can outgrow it and live, their adult life without having arthritis. So there are different types of arthritis, and based on that, we can understand a little bit better if a child may outgrow the arthritis or may need medication when they're an adult.
All right, so this is a little different because you deal with kids, and obviously I haven't dealt with a kid in like 30 years, but the kid is not complaining of anything, or is it the mom is telling you or the parents are telling you? How do they end up with you? What is the kid saying, or what is the mom telling you that the kid is saying that is bringing them all the way to you?
So there are very specific symptoms we see when a child has inflammatory arthritis. Typically, the symptoms are more in the morning when a child wakes up, and no child should be in pain in the morning when they wake up. So from seeing a child be uncomfortable, getting out of bed, having difficulty moving around in the morning, the parents already kind of can pick up that there's something that's not right because the child should jump out of bed and run around. So typically, kids will have not severe pain, but mild to moderate pain that will happen more in the morning, and they may have difficulty moving around depending on the area of arthritis. So if it's their fingers, they'll say that they have difficulty opening and closing their hands. If it's in their knees or their hips or their ankles, they may have difficulty walking in the morning. And the parents will say, it takes about 30 minutes or an hour or 2 hours, and they kind of warm up, and then they are able to move a little bit more freely and more comfortably. And so that is the main sign or the main symptom of inflammatory arthritis.
So paint a picture for me. What age are we seeing these kids at? Usually you're seeing them at what age?
So again, it depends on the subtype of arthritis, but we see patients that come to us from the age of 6 months to the age of 16 years of age.
But a 6-month-old can't tell you that, right?
So at that point, it will be more the parent noticing a swollen joint. So a swollen knee or a swollen wrist. And a lot of the times when a child has a swollen joint, they will go to the orthopedic doctor first. And so it takes some evaluation and some imaging before they get to us at that point. So it is rare to see them, for us to see them so early, but they can't present so early.
All right. So obviously the child's complaining of this, and when they go to the pediatrician, is this common? The pediatricians know about this? Because you're first going to a pediatrician before they ever get to you, right?
Right.
And so what usually happens when they go to the pediatrician?
So, again, it depends how many weeks or how many days they've had symptoms for. If a child comes to the pediatrician and they've been complaining for a couple of weeks, usually they'll first do imaging, they'll send them to the orthopedic doctor, and it does take some time for them to get to us. But a lot of times when a pediatrician has already taken care of patients with arthritis, or pediatricians that kind of have some sort of connection with a pediatric rheumatologist, they will be on alert for these patients that have what we call inflammatory symptoms of like morning stiffness, of swelling in the joints, and they will reach out for an appointment with a rheumatologist.
All right, so you see a patient who may have juvenile arthritis. The pediatrician sends you the patient with juvenile arthritis. Oh, by the way, is it more common in boys or in girls?
So again, it depends on the subtype, but the majority of autoimmune conditions and rheumatologic conditions are more common in girls, slightly more common in girls.
Okay. They end up in your office. What do you do? Obviously, you do a history. You examine the patient. Is there imaging done? What happens?
So the diagnosis of juvenile arthritis is a clinical diagnosis. Okay. You need a child under the age of 16 to have symptoms for over 6 weeks, and you need to find inflammation in the joints. So either a swollen joint or a tender joint that has restriction of movement, warmth, manifestations of inflammation. And that the parents tell you these symptoms have been going on for 6 weeks, or they went to the ER, 2 months ago and they had an x-ray and the x-ray showed swelling at the time, or, a year ago they were at the pediatrician and the pediatrician noted that there was something going on. So the symptoms have been there for at least 6 weeks. And then clinically, you find that this child has swelling, warmth, pain on motion, tenderness to palpation, and limitation of motion of one or more joints. Arthritis can happen in any amount of joints, from one to,
yeah. Okay.
The majority
now,
of them.
Right away, they go to treatment, they get on medication, or is it therapy? What happens?
So if they've had symptoms for 6 weeks, there are a couple of things we do. One of them is typically blood work. There are certain markers in the blood that don't make the diagnosis, but help us understand a little bit more about the type of arthritis. There are certain markers in the blood that kids will have that also adults with arthritis will have. And so those kids typically behave more like the adults with rheumatoid arthritis. That's only about 10% of kids with juvenile arthritis. Then there are other markers that give us other types of risks. So there is a marker called the ANA test that normally is checked for when there's a concern for lupus or other autoimmune conditions. But in kids with arthritis, it tells us if they have an ANA test that's positive, it puts them at higher risk of developing uveitis or eye inflammation. So about 20% of kids with juvenile arthritis can also develop eye inflammation. And that's something that we're always kind of on top of, and refer them to the ophthalmologist for evaluation.
So before we go a little further, is this juvenile arthritis similar to like the rheumatoid arthritis that we see in adults?
So only those 10% of patients that may have the rheumatoid factor or the CCP marker in the blood.
So the majority of them are not?
The majority are not. So
okay.
Those 10% of patients with rheumatoid factor positive, they'll behave like the adults with rheumatoid arthritis. And then the rest of the patients are patients that in their vast majority may outgrow the arthritis and may not have any issues as adults.
All right, so you see the kid, you diagnose it clinically, you start them on treatment?
So we do lab work and we send them to the ophthalmologist to evaluate for uveitis. If a patient has eye inflammation, then the treatment may be different than if they just have arthritis. So we have kind of like a stepwise approach to the treatment. We start with kind of the treatments that have been around the longest with the least side effects, and also depending on how many joints the patient has involved. So a patient that may have 1 or 2 joints with arthritis, we can treat them with what's called an intra-articular steroid injection. So it's steroids that go directly into the knee. So there's a needle that goes into the joint and the medicine goes there. But, in young kids, that has to be done under sedation. There are a group of kids that will respond alone to the steroids and they won't need anything else later on, any other type of treatment. So typically if they have 1 or 2 joints involved, I always tell the parents it is worth trying because they may never need any other type of treatment. The steroid injection may be what kind of gets them into what we call remission. We don't call it cure. We don't consider that there's an actual cure for arthritis, but there is treatment and kids go into remission, and it's like their arthritis is asleep for the rest of their life. And so the first treatment may be steroid injections, and then the next step are medications that are called DMARDs, or disease-modifying anti-rheumatic drugs, that are also medicines that are used in adults with arthritis. And then the step after that is biologic treatment. So in the past 20 to 30 years, there have been a lot of advancements in the treatment we use for arthritis. And in 2024, kids with arthritis can live a normal life as long as we treat their inflammation. There's no reason for them to be restricted in any way, to be limited. I have patients that are gymnasts, that are soccer players, that are like professional dancers, cheerleaders. They do track, they do volleyball. So they don't have long-term any type of limitation.
That is awesome. That is awesome. And you talked about the outgrowing it. What percentage of them will outgrow it?
So,
I mean, because if not, they're going to need medication for life?
So that group that behaves like the adults will likely need medication for life. We tend to give them breaks in their medication because it can be daunting to think as a child that you need medicine for the rest of your life. But the thought, or what is known in the research, is that about 1/3 of patients will go into remission. 1/3 of patients will need kind of intermittent treatment throughout their childhood years. So they'll get better, then they'll flare, they'll get medicine again, they'll get better. And then there's 1/3 of patients that will have issues long term. So, I mean, those are studies that are already somewhat old, and I think nowadays with the advancements in treatment, we see more of those patients that go into remission and don't need treatment later on.
Wow, that's good to hear. So the prognosis overall is very, very good for the grand majority of kids.
Yes.
All right. And when should a parent be concerned? When should, obviously parents are who are the ones listening to us. We're trying to educate our community. When should you be concerned about a child that possibly has this condition or any other autoimmune condition that's in your area of expertise?
Yeah. So definitely if you have a child who is getting up in the morning and is asking to be carried out of bed, cannot walk, has like a difficulty or a difficult time moving around in the morning, if that's something that's, you see it's consistent, like every day they wake up day after day, it's something that needs to be evaluated. It's not normal. A child should be able to get out of bed and run around and not have any type of restriction or limitation. And then if you notice a swollen joint without any type of trauma, like the child didn't fall, didn't have any type of injury, then it's something that should be evaluated by a rheumatologist.
All right. And if these kids that have the juvenile arthritis, are they more propense to have other conditions? Is there other associated conditions with it as well?
So the main one is uveitis or eye inflammation. Okay. So about 20% of those kids will have uveitis. And the main thing with uveitis associated with the majority of the types of juvenile arthritis is that it won't cause any symptoms. Patients will not complain of anything. It's what we call a silent inflammation. And so the only way of picking it up and diagnosing it is the patient being evaluated by an eye doctor and having a slit lamp exam. And so typically we send patients to the ophthalmologist, and they will see the ophthalmologist in specific intervals depending on the type of arthritis they have. Typically anything between every 3 to 6 months, they will need to have a full evaluation by a pediatric ophthalmologist to rule out and make sure there's no inflammation inside of the eye.
Okay. And then what about the possibility of those children growing up later on, giving it to their children? Is it more likely that a mom with rheumatoid arthritis is going to have a child with juvenile arthritis? What's the hereditary, the passing on in the genetics there?
Yeah. So there's not one gene, right? So it's a complex kind of genetic passage. And so a mom with rheumatoid arthritis may not necessarily pass it on to their child, but their child will have higher risk. And so if the child does start to develop symptoms, they should get evaluated right away. There's no way of kind of screening those children early on. We don't have a genetic marker or a test that may be positive very early. As I mentioned before, the diagnosis is clinical. And so the most we can do is for the patient to get evaluated as soon as symptoms start.
Wow. So overall, we've learned about juvenile arthritis, children who are complaining about getting out of bed in the morning, better when they warm up, swollen joints. Obviously, if it's been going on for some weeks and it's day after day, seek care. They obviously can reach out to the pediatric rheumatologist at Nicholas Children's, but if obviously they have to go through their pediatrician, bring that up to their pediatrician, and we're trying to educate the community. Now, the good prognosis and the grand majority of kids will outgrow it, and that's what I've understood and learned.
Yes.
Now, since we're educating the community, what other areas would you like to tell us about? Let's say we talked about lupus or some of these other vasculitis that we should be on alert for our parents that are listening.
Yeah.
Are there other signs or symptoms that are things that are concerning for a parent to say, hey, if you see this or that, you should bring it to the attention of your physician?
So the majority of the other conditions we take care of, patients will be pretty sick. And so a lot of times we see patients where one of the parents or a family member has lupus and the parent is concerned that their child may have lupus. It is rare to see a patient that has no symptoms and they have lupus, but a lot of times, because of the concern, what we see a lot as new patients in our clinic is patients that were seen by the pediatrician, and because the parents were concerned because of the family history, they had an ANA test that was checked. And so the ANA test is not a specific test. It's a test that is very sensitive, and it's a screening test, but it doesn't really help us make a diagnosis. So symptoms that we typically will see in patients with lupus or some of the other conditions are again, also joint swelling and joint pain that's more in the morning, rashes that don't go away, especially in the face, hair loss of bald spots, typically in the frontal area. In kids and teenagers, we can see a lot of weight loss because these conditions cause inflammation in the body. So weight loss for an unknown reason, fevers, and patients, again, they're typically sick. They're not patients that, are just kind of feeling their regular self, and then all of a sudden they have lupus or they have a vasculitis. They usually have some sort of symptom that kind of triggers an evaluation. A lot of the patients, especially with juvenile dermatomyositis or inflammatory myopathies and vasculitis, we end up diagnosing those patients in the hospital because they end up coming from the ER because they're sick.
All right. Well, good. Well, I want to thank you. Thank you for taking care of our kids in our community, first of all, and thank you for educating us on juvenile arthritis. And obviously, it's a condition that we needed to become aware of, and we are becoming aware of it. And you've told us the things that we have to be concerned about, but I'm happy to hear that there is optimism and there's good prognosis. And though it's not very common, thank God we've made a lot of progress because we've gone beyond just steroids,
Yes.
And I'm happy to hear that it's just not, you could be just injecting into the joints and you can control the condition as opposed to the systemic steroids, right?
So nowadays we try to stay away from the systemic steroids if we don't really need them. Once in a while, we will have a patient that has arthritis in many joints. So if they have, both ankles, both knees, they have a difficulty walking in the morning. A lot of the medicines we have that I mentioned, the DMARDs and the biologics, they do take time to work. So they may take about 6 to 8 weeks to kind of have stable levels in the blood and start having an effect. So some of those patients will give low doses of steroids to help them not be so uncomfortable because steroids have an immediate effect. But we really try for all our patients, including our lupus patients, vasculitis, we try to spare them the side effects of steroids because we know a lot of patients, especially in their teenage years, then have difficulty if they gain weight from steroids, they have difficulty losing the weight, they get stretch marks, they get acne, they get mood changes, difficulty with sleep, they can even develop high blood pressure and diabetes from chronic steroids. So we really try as much as we can to stay away from steroids, or at least if we give them steroids, it'll be a low dose and it'll be for a short period of time to try to help them be more comfortable and function in their day-to-day.
Yeah, no, we've realized that steroids are just not good long term. Now, do we know enough information about the biologics and the DMARD to know that long term those are going to be okay for these kids?
So what we know now, there are DMARDs and biologics that have been available for over 40, 50 years.
Oh, wow. So
and so those medications we know are safe.
Okay.
We know that there are certain lab tests that we need to check before we start. So a lot of the biologics require that you test for things like tuberculosis or hepatitis before starting, because if those infections are sleeping in the body, those medications can wake them up and can reactivate them. And so there are a certain number of tests that we do before and certain tests we do, usually every 3 months to monitor that patients are tolerating their medicine okay and that they're not having any side effects from the medicine. Obviously, like all medicine, there are potential side effects, but the doses we use typically are the lowest doses that the patient responds to. So that's to also minimize the potential side effects.
No, I was going to ask you, how do you know when to stop the medication?
Right. Yes, that's something I figured you would ask. So
because they may be feeling good from the medication, right?
Right. So there's not enough research to understand when to stop it, but there are studies that show that if you stop the medicine too quick, so around 18 months or sooner after starting, that patients are more likely to have recurrence of arthritis. So typically we keep patients on medicine for 2 years from the time that they have no inflammation before we start taking away the medicine. So it's a process that if they're not receiving the intraarticular steroid injection, if they get the DMARDs or the biologics, they will likely be on these medicines for at least 2 years before we start taking away the medicine and seeing how their body responds. So usually we monitor them while they're on their medicine if they're in what we call remission. The arthritis is dormant or sleeping. We monitor them every 3 months, but then once we stop the medicine, we may see them sooner, about a month and a half or 2 months after, to make sure that their body is not having inflammation again.
And it really is just a trial and error, right? And
Correct.
You try to remove the medication. If it comes back, you have to restart the medication again.
Correct.
Okay.
And there are patients that may not respond to the first medicine you start. So again, as I mentioned, we do a stepwise approach, but the first medicine we try may not be the medicine that takes away all the inflammation for that one patient. So we have other options. Nowadays, really, we have, many more options than when I started doing pediatric rheumatology, and there is no reason why a patient with arthritis should have any long-term issues or long-term damage from having had inflammation, because we have all the tools to take care of them. And something I didn't mention, there are patients that when they get to us, they've had inflammation for a while. So if you have inflammation in a joint, let's say the knee, for a long time, kids may not fully extend it or flex it, and so they lose some of that range of motion. And so after they've had control of the inflammation, we typically send these patients to physical and occupational therapy to help strengthen the area where they had inflammation and to help with the range of motion. But it is rare nowadays to have patients that have long-term damage or long-term issues from their arthritis. In the U.S. where we have medication available.
We have care, and we want them to be the gymnasts and the athletes that you have.
Yes,
That's awesome.
Yes.
Well, thank you. Thank you again for coming to join us. Thank you for educating us. Thank you for teaching us about juvenile arthritis and taking care of our children in our community. And on behalf of Miami Community Health and Dr. Anthony Gonzalez, take care of yourself and your family. And remember, if your child has inflammation of a joint, can't get out of bed, having difficulty in the mornings, seek care of a physician, go see your pediatrician, see your pediatric rheumatologist at Nicholas Children's. Once again, Dr. Anthony Gonzalez, on behalf of Yonit Sterba, once again,